I'm particularly delighted today to be moderating our panel discussion on self-delivery design. Joined with the excellent panelists that I will be introducing momentarily. So as you all know, there has been over the last few decades increasing utilization or access to health services in many countries, including low and middle income countries. There has also been really improvement in survivors, particularly maternal and newborn and child health survivors. However, over the recently, we've noted that these improvements have really plateaued. And then as it currently stands, many countries in low and middle-income countries are unlikely to achieve the Sustainable Development Goals for maternal and newborn, particularly by 2030, which is less than 10 years away, without a new strategy. So one of the hypotheses why mortality remains high, particularly maternal and newborn in low and middle income countries, is that despite although the improvement in the access, particularly facility delivery, has improved, but as of now, many countries are having their babies are being delivered in primary care clinics, as you can see in sub-Saharan Africa and India. And then we know that many of primary care clinics do not have a capacity to provide advanced care should complication arise. By contrast, in high-income countries like the US, nearly all babies are born in advanced facility like hospitals where a complication can be dealt with easily should they arise. Strategies that have been used to improve poor quality of care in primary care have really shown that they have shown that they are associated with a minimal impact of the last several years. So we know, for example, from the largest clinical trial conducted in India, that improvement in the quality of care at the primary care level, for example, what was done there whereby clinician adhered to a safe childbirth checklist. The address was very high, but despite that, improvement in maternal newborn outcomes were not significantly different in intervention hospital relative to a control hospital. So we also know that risk stratifications, whereby women who are likely to have a complication identified and referred, does not really work well, even in high-income countries. So it's difficult to tell. Anybody can have a complication anytime. So it's really vital that women have access or are able to deliver in facility with advanced care to handle these complications should they arise. Third, we know, you who have worked in low and middle income countries, that referral system do not really work very well. So when a complication or emergency arise, in many primary care facilities, there is no ambulance to to transfer women to a higher level, or if when ambulance may be there in some facilities, roads may not be in optimal condition to facilitate timely referral. So we lose really a precious time to get women to deliver where they can get optimal quality care, even in the case of complication. So what SDR is proposing is really shifting in thinking, so whereby conditions that require advanced clinical expertise are handled at higher level of care. These include tertiary and secondary level of care as appropriate, but also acute condition, including a chronic condition, and also a condition that require continuous coordinated care are provided at low level of the healthcare system, primary care, which are close to the community where people live. And context, when you think of it in the context of maternal and newborn health, really service delivery redesign would entail that deliveries are taking place in a hospital where advanced care can be provided, including cesarean delivery and blood transfusion should the complication arise. But at the same time, primary care level should be able to provide really quality antenatal and post-natal care as part of the overall package. So redesign is a system level intervention, not just one intervention. It's you can see it would entail really strengthening, high level hospitals that are able to provide those advanced care. That include providing them with enough equipment, training, clinician and the other providers to have competence to deal with to provide optimal care when those who are seeking care will arrive there. But at the same time, primary care level need to be boosted to really be able to continue to provide the continuous coordinated care close to where people live. We also need to educate people to really demand a high quality. A lot of work have shown that very often in low and middle income countries, people have low expectation of care. So even when they receive low quality of care, they still rate it as high quality of care. They need to be educated to ignite the demand for high quality of care. So at the same time, there is also a need to continue to improve access to high quality care through improving roads, but also providing a reliable transportation means. So lastly, in the line of redesign, there would need to be update to guidelines and other policies to really align well with the redesign strategy that country adopt. So here is some of the potential really benefits of design. The first key benefits is really improving survival in the context of maternal newborn health and newborn survival, but also because we would be able to focus or reinforce at the right level of care. So this means this efficiency will improve. So providers working in those advanced hospitals where they are receiving many cases, they are able to maintain their clinical skills. They can also continuously be trained to keep those skills. That is really vital to continue to provide high quality care. These are some among the benefits of service delivery redesign. So service delivery design, as you can imagine, is a system level intervention which really happens as a stepwise process. The first step being feasibility assessment. This one, the feasibility assessment really maps out health system capacity and identify gaps that would need to be filled by the service delivery design policy. Once the feasibility assessment is done, findings will highlight that a redesign is necessary and feasible. At that point, the second phase, which is co-designing daily care models, would follow. This phase would focus on not only identifying those models, leveraging existing resources, but also developing a costly plan and the financing options, and to ensure service delivery design is patient-centered. So a perspective of health care users should also be thought and incorporated in this design. So once all these are done, and then the improvement would be made, and then the rollout of the policy would happen. And then finally, it's vital to ensure there is a robust evaluation incorporated in a redesign to ensure that evidence are generated and shared to inform, scale up as necessary. So coming up to the first phase, which is really critical, the feasibility assessment, which would shed the light on whether the design is necessary and feasible. This phase is critical, and then it includes a lot of preparatory work and then stakeholders engagement to ensure there is a government buy-in, but also to define the scope of feasibility assessment, and also to really discuss and refine tools that will be used to correct any necessary data. So the second step includes then a correction of the data, focusing on primary and secondary as appropriate. And this data would be the data relevant to health system capacity, data relevant to access, and also correcting some data as necessary to get insight on the providers' thinking, and also get thought from the community. Once all these are done and the findings are synthesized, there should be a final consultation where discussion are held and the revisions are done as necessary, and then findings are shared with decision makers when they discuss and the decision is made whether a design is necessary, and then to move forward to consider redesign implementation. So in short, redesign as you've seen since yesterday, it's really system level intervention to work to be successful. It has to be government led. It's not a clinical intervention. It's a political decision whereby services are reorganized to ensure that patients receive care at the right place. Should take into context each country's specific context, and it should also, as highlighted, really be informed by thought from the community to ensure it's sensitive to their need. It's also, as I mentioned, a stepwise process which does not happen overnight. So all these steps need to be followed and ensure they are done appropriately to ensure the redesign is successful. Lastly, redesign can be applied to many conditions. We highlighted today and many yesterday that child hereby can also be used for chronic conditions, hypertension and diabetes. So things I would like to really acknowledge people who provide vital insights in all this work, their insights, their time. So I want to make sure they're acknowledged here.